against, I guess, Staph aureus or some bacteria. So it seems to work actually, and you can see the MIC is very low actually. Here, this is it's in light blue, and you can see in green, and you can see reaching up to 0.25. So maybe as a topical treatment, if we're thinking of a small lesion, maybe after some resection you want to apply, maybe as topical, but of course as systemic therapy, I don't know. I doubt we will have it as systemic therapy. Okay, now moving to clinical data, and this is probably what matters. Unfortunately, if you look at the evidence the hierarchy of the strength of evidence, we see the clinical data on mycetoma in the bottom because it's mostly case series. We have some prospective case series. We have mostly retrospective. So we don't have the best evidence. And this is for many reasons. I guess part of it, availability of the drug, support, funding of the research, which is, drug companies may not be interested in having expensive trials for mycetoma versus a bone marrow transplant with aspergillosis or candidemia and stuff like that. Okay, this paper is by Professor Mahjoub, and this is probably what made ketoconazole then the drug of choice for EU mycetoma. Ketoconazole was just introduced in the early 80s, and then Professor Mahjoub has started treating patients with it. And he had about 13 patients, 2/3 in Sudan, 1/3 in Saudi, different doses as you see in the middle, up to 400 milligrams, some with bone involvement as you see here. And then the response was, for the first time, we had improved, cured. These terms are unheard of in the past. So this made really a big impact. It's a small series, but made a big impact because we were in a dismal situation before that. So ketoconazole became a good drug to treat mycetoma, black grain mycetoma since then. Okay, then we had itraconazole. Voriconazole didn't seem to work well. Then itraconazole has been started in anecdotes and seems to work. So we had a few series. This is another ketoconazole study from India, also showed improvement. And we had a few other series which indicate that ketoconazole is a good drug. Of course, toxicity related to steroids biosynthesis, liver, and GI has hindered the use of ketoconazole. So this study from India showed 6 patients actually cured with ketoconazole. When we come to itraconazole, again, as I said, over the years there has been many anecdotes saying, well, it works, maybe patient get better. But I think this is probably one of the best series, a prospective series from Professor Fahal. And this was published just, I think, January of this year. And it was a prospective protocol where patients were controlled pretty well from clinical standpoint, histopathology, culture, imaging, ultrasound, and they were followed over time. So the protocol was of treating them with 400 milligrams for 3 months. Then because of the concern of toxicity, if I understood it right, it was reduced to 200 milligrams. And then surgery happens afterwards. And then the patients followed for a variable period, 1.5 to 3 years. And what has been found that the drugs help to kind of shrink or make it more encapsulated, so the surgery was easier. And I feel it's controversial point because for a drug to work well, you'd like it the fungus load to be less also. So if you debulk it, maybe the drug will work better. If you give the drug, maybe it will shrink and then you cut it better. So it's vice versa. I think it's a debatable point here. Um, 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 so surgery was easier, kind of here. But what has been noticed, many parameter has been looked at this study. Number of sinuses, disability, and you can see over time these improved. But however, when the patients were on 400 milligrams, response was better. And I've used itraconazole extensively, and my dose doesn't go below 400. I have a lot of patients with fungal sinusitis, probably over 100, and the dose I use for a long period of time is 400. It's a very, very safe drug, really. Voriconazole is far more problematic with the liver than itraconazole. So at the end of the study, one patient had a complete response, 9 patients partial, 3 stable, and 1 did not respond. Voriconazole, we have a couple of case reports, both from France, traveler to Africa. This is a patient with a lesion. I don't know if it's clear, but this is from the paper, so I don't have better images. And you can see it here, and then in the MRI you can see the lesion. And after 15 months of therapy with voriconazole, actually this disappeared and the patient was cured. 4 years of follow-up, no recurrence. This is quite encouraging with voriconazole. Then we have another case from France. Unfortunately, the details were not as much. And also some of the in vitro, they've done some in vitro data here showed very good susceptibility. And I don't know, terbinafine 0.015 is a bit peculiar. I mean, that's unusual.
More 5 minutes?
I'll show you just my case then.
Okay.
Because it is unique. Okay, so I think posaconazole, we have to know that it has been used for a patient by Dr. Ricardo Negroni in Sao Paulo with good results in medulla grisea and also mycetomatis. So posaconazole also seems to be maybe a good drug. Terbinafine, one study from Senegal, 23 patients, high dose, a dose I would not use. A gram of terbinafine is a bit concerning to me because of the liver, QT interval, all of that. But 25% were cured and 55% improved. Okay, the coast, coming to the coast because this is pivotal here. Fluconazole will not be treating Madurella, but if you try to treat with itraconazole, these are states kind of coast, then it's $34 a day for itraconazole, $80 a day for voriconazole, $130 a day for posaconazole. Who can afford that? When to stop therapy, I think, as I have probably alluded to, disappearance of the sinuses, radiology showing really complete healing, and of course needs follow-up because relapse can happen. Okay, my case, because it's a bit unique and we've tried a lot of drugs, so I'd like to show you quickly the case. This was a young man from Yemen who came to me, referred from a dermatologist, saying that this patient we could not treat, we want to amputate basically. He has 2 surgeries in the past, ketoconazole, itraconazole, nothing is working, it's reaching the calcaneum, and amputation is probably what we need to do. Okay, this is his picture. You don't see much, but inside there's a lot actually. And this, you can see the black grains and the swelling. This is closer. I don't know if showing well there, okay. So that was when we first saw him. And we did biopsy and showed the septate hyphae and it grew Madurella mycetomatis. He was having bacterial superinfection treated. And then we started therapy with a very high itraconazole because I believe your first bet is best bet, basically. If you want to treat aggressive up front rather than going and then trying to improve things as they go. So we gave him 600 actually, and terbinafine also 500 a day. But in January, which is about 2 months, he did not improve. I thought he improved, but he was not happy. Still has discharging sinuses. I think they may be better, but it's still grains and sinuses. I think you can compare the November and January, And you can probably appreciate there's some improvement, but the patient was having pain and he did not like it. So we switched actually to voriconazole, also a very high dose. This is not the usual dose, 200 milligrams TID. The recommended dose is BID. Just trying to really find out if voriconazole will be of any help. But it was actually getting worse by March. And these are the pictures. And he had surgery even before that. So it's surgery and voriconazole, and things were actually getting worse. So we did in March major debridement, and he was switched then to ketoconazole because he haven't used it, and we gave him the dose which is for Cushing syndrome. I mean, we gave him the dose which is very high dose, ketoconazole 600 milligrams, and in June, about 3 months later, things were not actually getting any better. Again, a major surgery. Then we had posaconazole by August. So we started him on posaconazole liquid. And we did also surgery. And then looks like we had some improvement, maybe. And he had also more debridement then. And in December, we were very happy then because almost healed, I mean, some swelling, but things were really good. So we kept him on posaconazole. However, January, just about a month afterwards, things were getting worse now. I don't have a picture of that, unfortunately, but it was getting bigger, started to have sinuses, things, he's clearly relapsing or worsening. I don't know, I think we have controlled him for a little while only. So we stopped it after 3 months. I mean, things were clearly worse. So we said, okay, we have ambisome. Let's try ambisome on you. After also doing some surgery. So we've given him ambisome, and unfortunately he reacted even worse than regular amphotericin B. Creatinine up, hypokalemia only in 7 days. Okay, we said, maybe you have to go for amputation, but let's try one more thing, combination therapy. So we've given him IV high-dose itraconazole, 200 milligrams BID, which is double the recommended dose, and caspofungin together, 21 days, observing him closely, nothing. So he said, well, you have to go for amputation. So he said, no, I'm going back to Yemen, I want to try some herbs. So he went back, and he has my cell phone, so he called me 6 months afterwards, and he said he had amputation, and he's happy now because he's been through a lot. So some cases, whatever you have, really, really difficult, and this illustrates that very well. So in conclusion, I'm thinking I'm over my time. M.mycetoma is a significant disease burden that needs more recognition and collaborative work, and really the work between Khartoum and Rotterdam has been really excellent. I think we have to be very proud of that. Data on therapeutics still scarce and of low quality. We need to improve on that. Several antifungals have a potential in the treatment of mycetoma, as I have shown you. And possible efficacy of the new marketed antifungals can only be suggested from the in vitro studies and anecdotal experience. And at the end of the day, can we afford them or not? We need prospective randomized trials. If we have the volume, maybe multi-center, multinational, to do good studies that really can give a clear recommendation on how we deal with such difficult infection. Again, prevention is definitely better than treatment and cure, and education campaigns for early diagnosis can make a major impact on the outcome. With that, I conclude, and thank you for your attention.
Thank you very much, Dr. Hail. We will leave questions to the end, and I hand over to my co-chair, Dr. Sullivan.
The next speaker is from a different discipline, Dr. Hassan Rasool Al-Fadil. He's a member of the Department of Pharmacy, Al Jazeera University, Medani, in the central part of the Sudan. and actually it is the center of the mycetoma belt in this country. Dr. Al-Fadil is trying hopefully to answer the question, is there any other alternatives than the costly toxic conazole groups? He's talking about an alternative medicine for mycetoma, and he's going to talk about herbal treatment. I wish that he will have some success avoiding all the toxic effects and the financial burden of $130 a day for our poor patients. Here we are, Dr. Hassan Rasul.
Bismillah ar-Rahman ar-Rahim. Bismillah ar-Rahman ar-Rahim. First, I would like to thank Professor Fahel and the organizing committee for the organization of this high-level conference. Directly, I have got 15 minutes. I will go directly to the presentation. Under this title, M.mycetoma, drug resistance and study of drug resistance and plant-based pharmacotherapy. This is actually was being headed by Professor Al-Hadi, Professor Ahmed Fahel, Professor Abdullah Osman, and Dr. Windy from Erasmus. I'll go through into the definitions and some pictures from Jazeera. This patient is coming from Jazeera, and everybody knows the etiology now is for the either true fungi for the EU mycetoma and bacteria for the actinomycetoma. Concerning the impact, everybody knows it is a serious health problem in our region, particularly of the Jazeera. Magnitude of the problem now, we have got about 5,000 patients as a mycetoma research center of Sabah. Okay. Most of the patients of EU mycetoma come from Jazeera, and the Jazeera became the homeland of mycetoma. The treatment depends mainly on the etiological agent and the extent of the disease. I went here very fast to get into the study. What is so disappointing about the actinomycetoma is amenable to medical treatment, although for a very long periods of time. But the medical treatment of EU mycetoma by various antifungals is quite inadequate and disappointing. And the story of the Dr. Hayal Al-Abdali, I'm happy that the patient at last was amputated. Otherwise, I thought he was being dead. The current solution is the combined medical and surgical treatment, the gold standard in the EU mycetoma. The problem for the current therapy, and this is was our main objective, the current therapy, current treatment is quite unsatisfactory concerning due to the drug therapy of azole derivatives in general. The high relapse rate, it has got a high relapse rate and extensive for very expensive for patients and health authorities. The Voriconazole, the patient might need a huge amount of money. The popular treatment regimes used now is for the ketoconazole, 400 to 800 milligrams per day. And for the Itraconazole, 400 milligrams per day for extended periods of time with a mean duration of 9 months to 12 months. And this is too much for azole derivatives. And this case of Voriconazole, actually there is a relapse. This patient was given a Voriconazole, the triazole derivative. And the patient was given in February 1999, and after 4 years, the patient, as you see on the right part, he is infected right soul 4 years after Voriconazole treatment. This was being in May 2004. You see, it seems after 4 years, the infection, there is a recurrence. So that means the voriconazole the voriconazole is a very, very, very expensive drug. Very expensive drug. The patient needs more than $30,000 to have the real dose. To have the real dose. And for this, there is a relapse after 4 years. That means cost-wise in Sudan, this voriconazole is not applicable. Cost-wise, this is a microscopic M.mycetoma lesion. After 1 year of treatment with itraconazole, you see it is encapsulated, and it is clear that the drug is quite useless. It is not doing any job. This is a combination. This is from Professor Fahal. This is a combination of itraconazole with surgical debridement. All those patients are coming from Jazeera, by the way. Being a neglected burden, this goes without saying. It needs more attention now to my study.